Welcome to AETCM, the emergency medicine channel. So, in the path of cardiovascular emergency, today's our topic of discussion cardiac tamponade and cardiogenic shock. So, first is a cardiac tamponade. So, what it means cardiac tamponade is a medical emergency. So, it denotes defined as it is a clinical syndrome. It is a accumulation of extra fluid in the pericardial space. Ultimately, it will result in the reduced ventricular filling and subsequent hemodynamic compromise. So here we told the main term is accumulation of extra fluid in the pericardial cavity. So if you want to understand this concept, first you have to know what is meant by pericardial area, where it is, and then we told like accumulation of extra fluid. That means what is the normal amount of fluid that will be in the pericardial area. To answer this, we can see this slide. So usually your pericardium is a covering of the heart, means so it will cover like this and then it will hold in specific area in your mediastinum, in middle mediastinum it will wrap around the heart and then it will hold, so it will avoid the misplacement of the heart. That is the main purpose. So most of us will confuse with covering and then layers. So layers in the sense that is our epicardium, myocardium, endocardium. These are the layers of heart or layers of heart walls. So most of us, if you ask regarding layers of heart, means most of us will tell like a pericardium, myocardium, endocardium. That is wrong. Pericardium is a covering. Layers in the sense are epicardium, myocardium, endocardium. So again, coming into pericardial covering, we have two major parts. In pericardium, we have two major parts. That is the fibrous pericardium and then serous pericardium. So outer is a fibrous pericardium, inner is a serous pericardium. So again, serous pericardium have a two major portion, that is the outer parietal layer, inner visceral layer. So outer parietal serous pericardium, inner side visceral serous pericardium. The space between the parietal and visceral area, that is called pericardial area, so or pericardial cavity. So pericardium have a two major parts, outer fibrous, inner serous. Serous again we are dividing into two, that is the parietal serous pericardium, visceral serous pericardium. The space between the parietal and visceral serous pericardium, that is the pericardial cavity. So in this image we can clearly see, so this is the outer portion, this is the fibrous pericardium, and then inner, these two are serous pericardium. So in serous we told two major portion. No, so this pink one is a outer parietal serous pericardium. This one is a inner serous pericardium, right? Outer parietal, inner visceral pericardium. So the space between the parietal and visceral, this is the pericardial cavity. So it is the first question answer. Second thing, what is the normal amount of fluid? It is the 15 to 50 ml of serous fluid. So normally in the pericardial area we will have a 15 to 50 ml. But because of the elasticity nature, in acute setting it can carry the 80 to 120 ml. So if it is going beyond 50 ml means that is the your pericardial tamponade or pericardial effusion. Effusion in the sense the fluid will collect very slowly. It won't collect as a sudden manner. So it will take days to weeks. Tamponade in the sense that will collect suddenly. So that is called difference between the pericardial effusion and then tamponade. So in acute setting it can accommodate 80 to 120 ml. So what is the pathology or pathophysiology that will occur behind the cardiac tamponade? So we told, so externally in pericardial area there will be a collection of fluid that will prevent the relaxation of the heart. So here we can see that this is the normal portion, easily the heart can contract and relax. But here there will be an accumulation of fluid in this pericardial area. So it will prevent the relaxation of the heart. So it will prevent the diastolic pace of the heart, in other words. So what will happen because of the dilation? Diastolic, if it is prevents means, so inside, so whatever venous return coming from the systemic area, that will prevent. So venous return will reduce. So if venous return will reduce means that will cause the decreased stroke volume, right? So input reduce means output also will reduce. So it will cause the low cardiac output and then causing the signs of shock. So what might be the etiology? blunt trauma, cardiac rupture, heart surgery, any medical procedure, angioplasty, central venous catheter or pacemaker wire insertion. While the time of insertion, accidentally it may hit on the coronary arteries or aorta or vena cava, wherever. So it will cause the UR effusion. And then hypothyroidism. How hypothyroidism will cause means, so hypothyroidism mainly it will breach the permeability of your pericardium. Means usually your pericardium is impermeable, so it won't allow any fluid inside the pericardial area. But hypothyroidism, what will happen means, it will breach your permeability. So your protein like albumin, easily it will enter into your pericardial area. So we know albumin is a colloid function. So albumin what will do? So it will absorb or it will adhere the, otherwise it will withdraw the fluid from the outside area to the inside area. So where it present, it will absorb, otherwise in other word we can tell us it will withdraw fluid from the capillary area to the outside area. So that is the reason that is causing the cardiac tamponade. Penetrating trauma, pericarditis, pericardial effusion, and then radiation related in oncological radiation therapy, renal disease, and then aortic dissection. So in assessment part wise, how the person will appear. So initial impression wise, anxious and restless, report shortness of breath, chest tightness, and then dizziness. So if you are doing physical examination, here you can find the three major things, that is the triad that calls Beck's triad of cardiac tamponade. So what we'll see in that case, we can see the jugular venous distension. So what might be the reason? So here jugular venous distension, mainly we told like two major condition it will occur. If the intrathoracic pressure increases means, that will cause the jugular venous distension. Again, if any problem in the drainage, problem in the heart means, that will also cause the jugular venous distension. So here the cause is the problem in the drainage. Second is a diminished heart sound. So because of the fluid accumulation, while the time of auscultation, we can see the diminished heart sound, otherwise muffled heart sound. And then hypotension, again input reduce, so output also reduce. It will cause the, because of the problem in the contractility, it will cause the hypotension. If the person is inside the hospital, otherwise if the person have the intra-arterial catheter, we can find the pulses paradoxes also. So other signs like a skin like a cold, pale, mottled or cyanotic skin, tachycardia, and then weak absent peripheral pulses also will be there, narrowing pulse pressure, pulses paradoxes, and then it will mimic the signs and symptom of or clinical feature of heart failure also, like dyspnea, orthopnea, jugular venous distension also we can see in the case of cardiac tamponade. So if you take the ECG, here we can find out the low amplitude of QRS complex and then T wave. Low amplitude QRS means, if you take the ECG, there you can find the height of the QRS complex is less than 5 millimeter. So we know this is the one large box is the 5 millimeter, right? So here you can see the height of the QRS is less than 5 millimeter. That is the low amplitude QRS, and then we can see the changes in the ST elevation, non-specific T wave changes also will occur. And then how we can manage. So cardiac tamponade, main set of definitive treatment is a pericardiocentesis. So we'll put needle in the pericardial area and then we will aspirate. So if we are removing fluid, the person halfly the person will recover. Again the remaining half we have to find out the cause for the pericardial effusion. If we treat it means, the person fully will recover. So the main treatment is we have to put the needle and then we have to find out the cause. So those are the things will happen in the definitive area only, otherwise inside the hospital. So in our pre-hospital, what we can do, so we have to give the same thing, whatever we are doing in our assessment and management part, we have to see size up and then we have to assess the mental status, we have to check the primary survey, so general impression, and then we have to go for the airway, breathing, circulation, disability exposure. No? The same thing only, we have to adequate oxygenation, ventilation, and then we have to place the person in the cardiac monitor and establish IV access. If IV fluid permits means, based on the online medical direction, we can go for the IV fluids. And then frequently we have to check the mental status of the person, heart rate, respiratory rate, breath sound. So everything, the vital thing, we have to frequently recheck. So and then we should not waste time in the pre-hospital region. As soon as possible, we have to shift the person to the closet or appropriate medical center. So this is the procedure note regarding the pericardiocentesis. So when we are doing, when we should not. The indication means mainly two purpose, therapeutic and diagnostic purpose. Contraindication, aortic dissection, any coagulopathy, thrombocytopenia, myocardial rupture, severe pulmonary hypertension, and then pacemaker, other cardiac devices. And then pre-procedure, before procedure, we have to ask about the anticoagulant, if the person is taking any anticoagulation or not. If they are taking means you have to withhold for some time, not some days, and then we have to with the echo we have to check that is the fluid is free from coagulation, any blood clot is there or not. Localization means effusion that will collect in a diffuse manner, so it will spread all over the pericardial area. Localization means that will collect pouch, so that will collect pouch in manner, so in localized area that will be there. So and then before that we have to check the all vitals. So these are the common 6 possible drainage sites. So we'll approach schistoid or apical or parasternal area. So procedure wise, first we have to place the person in the 30 to 45 degree angle. Before that we have to take the informed consent and then platelet coagulation studies, everything we have to do, and then we have to select the site, we have to sterilize the area, and then here we are using 3-inch or 16 to 20 gauge needle, and then we have to put the needle in the 30 to 45 degree angle, direct the left shoulder. So this is the way. So left shoulder 30 to 45 degree angle we have to insert, and then while insertion we have to aspirate and then insert. So the manner is we have to aspirate, insertion, mean the same time we have to aspirate and then insertion. Once the fluid encounters, furthermore we should not advance the catheter or needle. And then for drainage we can aspirate and discard, otherwise not discard, aspirate, and then we can send some sample for the laboratory investigation. If the effusion is large, if we want a continuous drainage means we can put a 3-way stopcock. And then after that, once after and post procedure also we have to recheck the patient status. So vitals, mental status, everything we have to recheck. Mainly BP, those are the things, jugular venous distension we told, no, those are the things we have to recheck. And then blind pericardiocentesis, there we did with the help of USG, right? So with the USG we are doing. The other condition like a blind pericardiocentesis, this is mainly performed in the emergency situation. If suddenly the person get deteriorate in the pre-hospital region, otherwise if we don't have any USG at the time, we don't have any USG in the in-hospital setting means, in that case we are doing blind pericardiocentesis. Here the one difference is with in needle we put a alligator clip, so that alligator clip that will connect with an ECG. So the same technique will insert, and then while the time will aspirate and then insert. Once if we see any changes in your ECG like ST segment elevation means, that is that will indicate the contact with an myocardium. So once if it hit your myocardium means, that will cause the ST segment elevation, right? So that is what we can understand, we are hitting on the myocardium, so still more we have to withdraw and then we have to aspirate. That is the blind pericardiocentesis. So the complication wise, so while the time of insertion we can hit over the nearby arteries or nearby structures like a pleural cavity. It may cause the pneumothorax, hemothorax, bleeding, and then infection, then pleuropericardial fistula, there will be a connection, and then hypotension, again it will cause the death in 0.09% cases. So that is the thing regarding the cardiac tamponade. Next topic is a cardiogenic shock. So before getting into the shock, we have to know about the what is mean by circulatory shock, and then what are the classification of circulatory shock, that we have to know. So first we have to know about the circulatory shock. So what is mean by circulatory shock? Circulatory shock in the sense, it is a state of changing aerobic to anaerobic metabolism due to an hypoperfusion. So it is a state of changing aerobic to anaerobic metabolism because of the hypoperfusion. Means, so what is the normal physiology? So here we have a cell, so your blood will provide the oxygen, that is a perfusion. Via perfusion your cell will get the oxygen, that will put it in the some metabolism, there is a aerobic metabolism, right? In the presence of oxygen, there will be a metabolism will happen. So at final, you will get a ATP, adenosine triphosphate, and then you will get a carbon dioxide, and then we will get a water. So this is the normal mechanism in the presence of oxygen. But in the case of here, we told because of the hypoperfusion. So hypoperfusion means your cell getting a decrease amount of perfusion. Otherwise, in other term, your cell getting low amount of oxygen, or without oxygen also it will run. So if oxygen is not there, means what your cell will do, it will change the process of food making into aerobic to anaerobic. That is a one method to another method. So oxygen is not there, means it will go with an other pathway, that is called anaerobic pathway. Anaerobic pathway. In anaerobic pathway, what will happen means, in normal pathway, what is happening, ATP. In anaerobic also, ATP, adenosine triphosphate, will form, but is the end product here is a lactic acid. So that is the major complicated one. So in normal pathway, here you will get a CO2 and H2O, but in anaerobic pathway you will get a lactic acid. So that lactic acid will put a person in the furthermore complication. That is why we told shock is a state of changing aerobic to anaerobic metabolism because of the hypoperfusion. Hypoperfusion, it is changing metabolism, that is right, but the end product is a major concern. Lactic acid, that will cause the furthermore worsen of the condition. There is a what is meant by circulatory shock. Second one is a what are the classification or what are the types we have in the circulatory shock. So we have a one classification like Weil's classification, WEILS, Weil's classification. So we are categorizing into two major things. So central and peripheral. Central and peripheral. So central, what we have mean COH, CO means C in the sense cardiogenic, O in the sense obstructive. Peripheral, we have a two major things, that is a HD, COHD, high in the sense hypovolemic, D in the sense distributive. So to easily we can remember, like if you remember the perfusion triad, it will be easy for us. So what is meant by perfusion triad? There will be a pump function and then container function, content function, right? Pump in the sense that is denoting the heart function. So container in the sense blood vessel, content in the sense blood. So if the heart is pumping correctly and then your blood vessel working correctly, otherwise no breach in the blood vessel, it is acting correctly, and then if you have a adequate amount of blood will means, then you will get a nice perfusion, otherwise you will get adequate perfusion. The same thing only cardiogenic means, so the problem in the heart, the pumping failure, that will cause the cardiogenic shock. What might be the reason? Any heart failure or any myopathies or any infective heart disease or any valvular disorder, congenital disorder, that might be the reason of cardiogenic shock. Obstructive shock in the sense, any mechanical obstruction like tension pneumothorax, tamponade cardiac, pericardial effusion. So those are the pleural effusion, those are the mechanical obstruction that will comes under the obstructive shock. And then third one is a hypovolemic shock. Hypovolemic means your dehydration, any hemorrhage. So third spacing, spinal shock, those are the things comes under the hypovolemic shock. It denotes the content failure. So there will be a there won't be a adequate amount of blood. So that is a content failure. And the distributive in the sense that denoting the container failure means that will affect your blood vessels. So like anaphylaxis, septic shock, those are things will affect the distributic, those are things comes under the distributic shock. So these are the Weil classification. We are categorizing into two major categories, central and peripheral. Central includes CO, cardiogenic and obstructive. Peripheral indicates the other than the heart and lung. So it is indicating the hypovolemic and distributive. So in this view, if you are looking this slide means it will be easy. So cardiogenic shock in the sense that will comes under the central shock. There failure in the pump, not in the container, not in the content. So that same thing. Decreased cardiac output, evidence of tissue hypoxia in the presence of adequate intravascular volume. So there is no failure in the content. So what are the criteria? So mainly this thing will perform in the inside hospital. If the person have a sustained hypotension, systolic blood pressure less than 90 mmHg for more than 30 minutes, reduced cardiac index. Cardiac index means, so the amount of blood that is ejected from the left ventricle in a minute to the body surface area. So the amount of blood that is ejected from your left ventricle to the body surface area in 1 minute, that is the less than 2.2, and then, or if you are the person have a Swan-Ganz catheter means pulmonary capillary wedge pressure is more than 15 mmHg, and then right ventricular end diastolic pressure is more than 10 mmHg. Just for the knowledge you can remember. So what might be the causes? We are categorizing into two categories: coronary related, non-coronary related. Coronary related means myocardial infarction, acute coronary syndrome, ischemia. Non-coronary means stress related pericardial effusion, tamponade, valvular abnormalities, heart failure and arrhythmias. So dysfunction like systolic, diastolic dysfunction, valvular dysfunction, any other mechanical complications. So assessment wise, so based on the severity, the person, if the person is compensated cardiogenic shock means there will be a no breach in the mental status, they are appear normal. But if any problem in the cerebral perfusion means that will cause the restlessness, agitated and confused. So in the breath sound we can reveal the crackles. So why? Because the crackles means there will be a cardiogenic pulmonary edema, so that will cause the crackles. So circulation wise we can find the skin is ascent, cyanotic, cool and extremities are mottled. So peripheral pulses, if you are palpating means there will be rapid and faint. So if it is arrhythmia means there will be irregularity. So jugular venous distension will be there, and then peripheral edema will be there. The pulse pressure may be low, and then usually it is a tachycardia, and then patients shows signs of hypoperfusion. So hypoperfusion to the cerebri means that will cause the altered mental status and then decreased urine output. Ultimately patient develop systemic hypotension, that is a systolic blood pressure of less than 90 mmHg or mean arterial pressure of less than 30 mmHg. So what is the management? Again the same thing. Here the problem in the pumping aortic, there is no problem in the content and container. So if you want the heart want to pump effectively means we have to give the inotropic. So we have to strengthen the contractility. So in pre-hospital what we can do, the same thing, we have to limit the patient activity, we have to assess the mental status, airway, breathing, circulation, disability exposure, pulse oximetry. If the SpO2 is less than 94, we can go with a supplemental oxygen, and then you have to take the ECG and then place the person in the cardiac monitor, IV access, and then maintain body normal temperature you have to maintain. IV fluids, again if it permits means we can do. So if the person is inside the hospital means what we'll do, so we'll place a USG probe. With the USG probe we'll check the inferior vena cava, and then what about the cardiac contractility function. Based on that we'll give fluid. But in pre-hospital that won't be, we won't get, otherwise we won't get a time, mean the same time we won't get that much of advanced equipment like USG, that is very rare in our pre-hospital region. So at the time what we can do, just to give a 100 to 200 ml of fluid bolus. So then after the fluid bolus, check the person's mental status and then vital signs. If any deterioration in the mental status or if any deterioration in the vital signs means, then don't give further fluids. You can quickly transfer to the person to the definitive care. So that is the way we can give the fluid judgment in the pre-hospital region. Again, we can get a help from the online medical director also, but this is the some sort of idea what we are doing in the pre-hospital region. So here we have to give the inotropic agents like noradrenaline or adrenaline. Mainly inotropes are dobutamine and then milrinone. Apart from this, we have a dopamine, noradrenaline, adrenaline also we can give. And then if any life-threatening arrhythmia is there means we can go with an antiarrhythmics. If the person shows any symptom of ACS or like your CV related means, we can think about the fibrinolytic checklist. Based on that, we have to transfer the appropriate care. So do your best. Shalom.